Dr. Jehad Buraiki is a colleague. He's a consultant cardiologist in King Faisal Specialist Hospital. He's the medical director of the heart transplant program and deputy director of King Faisal Heart Institute. He is trained in Canada in 2 different centers. I think he managed with his team to be the most active heart transplant center in the Kingdom of Saudi Arabia. They managed to transplant 19 patients last year and 14 patients till now in this year. We'll hope for the best. And we are happy to have Dr. Jehad Buraiki to talk to us today about the improving outcome in heart transplant. Dr. Jehad.
Okay, thank you. Assalamu alaikum. Good morning. I would like first to thank the organizing committee for inviting me to speak about an update on improved outcome of heart transplantation. It has been 40 years since the first human heart transplant was performed on 3rd of December 1967, Dr. Christian Bernard in South Africa. The media attention that surrounded this event was quite enormous. This patient made initial good recovery, but unfortunately died 19 days later because of pneumonia. The second heart transplant had also a good recovery, and he left the hospital, and that led to a guarded optimism. However, this initial enthusiasm quickly curbed when it became evident that the survival of these patients was measured in days or weeks. And this was because of lack of or inadequate understanding of the early post-op complications, lack of tools to address acute rejection, opportunistic infections, and allograft vasculopathy. It's worthwhile mentioning that the second heart transplant patient died 19 months later because of acute myocardial infarction, which was quite a shock to the community, medical community. Over the following 2 decades, with refinement of the donor and recipient selection, advances in immunosuppression, advances in surgical technique, and prevention and treatment of infection, this led to an improved survival, and heart transplantation became a viable option for patients with end-stage heart failure. And I'll talk about every one of those in more details later in my presentation. This slide shows the positive impact of the different advances, be it in the diagnosis, treatment, or surgical technique. And the most noticeable one was in the early 1980s when cyclosporin was introduced with remarkable improvement in survival. This slide shows this is from the last ISHLT report in 2010, and it shows that the survival, which is represented in the red, I know, but it doesn't show. Okay, all right. The red line, which represents the period from 2002 to 2008, and you could see that the 1-year survival is approaching 90% now, and with a 5-year survival of approximately 70%. Not only that, but if you look at the quality of life, 90% of the patients almost have no limitation of physical activity. About 40% of patients resume either a full-time work or a part-time work. Now, this improvement occurred despite a change in the population, with sicker and older patients are being referred and considered for transplantation. So we have older patients, patients with complex congenital heart disease, patients requiring mechanical circulatory support as a bridge to transplant, and an increased number of free transplant candidates. Although the number of patients who have underlying congenital heart disease still represent a small proportion of the population, but it has been increasing over the years, as well as with the increasing number of patients who are transplanted at younger age, more and more patients are undergoing retransplantation. Just to show an example of how these patients are higher risk patients, if you look at the patients who receive temporary circulatory support, their relative risk ratio for 1-year mortality is 2.73. While those with congenital, underlying congenital heart disease, it's almost approaching 2.27. Now, starting with the older patients, this slide shows the age distribution by era, and it clearly demonstrates an increasing number, which is represented in the yellow bar, of patients who are transplanted between the age of 60 and 69, with a slight increase in the patients who are above the age of 70. Older age patients are at risk for transplant, lower transplant survival. Although they have lower risk of rejection, they are at increased risk of infection and allograft vasculopathy. Again, this is from the last report in 2010. If you look at patients who are above the age of 70, they have lower survival rate compared with the rest of the groups. Now, with the advances made in cardiac surgery, more and more patients are surviving until they reach adult age, and many of these patients develop heart failure despite repair, palliation, and some of them have uncorrected lesions. And those patients, as I showed, they have higher risk of mortality, and the reason is twofold. One is technical, because of adhesions from previous surgery, higher incidence of collaterals, technically more challenging surgery because of the complexity of underlying congenital heart disease. They are also at higher incidence of sensitization. As I said, it's a strong risk factor for 1-year mortality. However, those who make it in the first, and this is represented in the green line, those who makes it in the first 3 years, they have a survival advantage later in the course of their life. Mechanical support device, with the increasing demand on heart transplantation and shortage of donors, more and more patients are bridged to transplantation with mechanical support device. And it's like anything else, it's not without a price. And the downside to this is that those patients are at increased risk of rejection, infection, stroke, and bleeding. If you look at the number of patients or percentage of patients that are bridged to transplant with a mechanical support device, it's almost approaching 24%. If you look at the survival curve for patients who are bridged with circulatory support device, represented in the blue line, is quite inferior to the rest of the patients who are not bridged with assist devices. Now, with increasing patients who are transplanted at younger age, more and more patients are requiring retransplantation. And those patients, studies have shown that they have a lower overall survival, and that reflects an increased rate of sensitization and as well as long time or years of immunosuppression. And the highest risk group for retransplantation are those who are retransplanted within 6 months after the primary transplant, and those who are transplanted for acute rejection or early graft failure. This shows the survival of patients who are retransplanted by era, and despite the lower survival rate compared with the rest of the population, it has improved over the years, and now with a 1-year survival of approaching 80% and a 5-year survival of about 65%. Now, as I mentioned earlier in my presentation, the reasons for improvement in the outcome is four reasons. First of all, there has been an improvement in the donor and recipient selection. The acceptance of the heart is a two-phase process. The first step is to rule out contraindication to heart donation, including ruling out significant heart dysfunction or coronary artery disease, transmissible diseases or malignancies, except for primary CNS tumors with low metastatic potential. The next step is matching the donor to recipient. And the first thing, of course, is ABO compatibility. The second, which is more important, is body size compatibility. And in general, we have been accepting a 20% difference in height and weight between the donor and the recipient. However, in patients who have pulmonary hypertension, it's advisable and recommended to use equal or higher size donors. Other characteristics that are associated with outcome are donor age. Donor age of more than 40 has been associated with lower survival and higher incidence of allograft vasculopathy. Left ventricular hypertrophy of more than 14 millimeter has been associated with lower survival, and gender mismatch. A female donor to a male recipient also has been associated with lower 1 and 5 year survival. Now, moving to the surgical technique, the two surgical approaches for heart transplantation has been the historical heterotopic heart transplantation versus the orthotopic heart transplantation. In heterotopic heart transplantation, the donor heart is implanted beside the native heart. This is a technique which was first performed by Bernard in 1974, but it's rarely done today. This is the second approach, which is the orthotopic, where the donor heart is implanted in the normal location of the native heart. And the first approach, which is called the biatrial approach, this was introduced by Norman Shumway in 1960 in a dog model, and then it was used in humans. Later, though, another approach was introduced by Sievers, where the donor right atrium is anastomosed to the inferior, directly to the inferior and superior cava of the recipient. And the advantage of this technique is that it is associated with less disruption of atrial geometry, better RV function, less tricuspid regurgitation and mitral regurgitation, and less sinus node dysfunction. Now, from there, we'll move to advances in immunosuppression. And following the introduction of cyclosporin, with the positive impact on survival, several other immunosuppressive agents were introduced. And several studies have looked at to address the following question. Is there a need for early induction therapy? The second question is, what's the best combination of immunosuppressive agents? And the third is the safety of early withdrawal of corticosteroids. Although that over still 50% of the patients are receiving induction therapy, to date, there was no survival benefit established in the use of induction therapy in these patients. However, it is the weight of evidence support the use of induction therapy in two groups of patients. Those who are highly sensitized, and the other group is the patients who have renal failure, significant renal failure at the time of transplantation, to allow the kidney to recover before introduction of calcineurin inhibitors. Now, what about maintenance immunosuppression? Most of the programs use triple therapy, including calcineurin inhibitor, MMF, and prednisone. Now, in the last 5 years, there has been a steady increase in the use of tacrolimus, which has almost replaced cyclosporin. And this following studies showing decreased rejection episodes with the use of tacrolimus, although there was no survival benefit. MMF has replaced azathioprine, and most of the programs are trying to withdraw steroids later after transplantation. And from this report, which is the 2010 report, still 40% of the patients, despite that, are still on steroids 5 years after transplantation. This shows the most common combination, and as I mentioned, the most common combination is the tacrolimus with MMF. Now, management of acute rejection has also evolved over the years, depending on the histological type, cellular versus humoral. This is an example of a patient who has cellular rejection, where you see lymphocytic infiltrate with myocyte damage in 2 foci. The grading of the cellular rejection has been updated and was published in 2004, and the treatment use of intravenous corticosteroids for those patients who have moderate rejection, and use of cytolytic therapy is kept to those only with hemodynamic compromise. With increasing clinical experience, diagnosis and treatment of antibody-mediated rejection has also became better defined. This is an example of somebody who has humoral rejection. You could see endothelial swelling, intravascular macrophages, and this is confirmed with a C4D staining, immunofluorescence staining with a donut sign. And the treatment for those who have hemodynamically compromised humoral rejection include intravascular corticosteroid, plasmapheresis, intravenous immunoglobulin, and rituximab to reduce the risk of recurrence. From there, I'll move to the transplant vasculopathy, and this is the most common cause of late graft failure. Not only that, but it's also associated with lower survival, represented in the red line compared with those who have no allograft vasculopathy. What are the risk factors for allograft vasculopathy? There are non-immune and immune risk factors. The non-immune risk factors are hyperlipidemia, hypertension, diabetes, hypercystinemia, and older donor age. Immune risk factors include HLA donor-recipient mismatches, recurrent cellular rejection, and antibody-mediated rejection. There is increasing evidence that viral infection, particularly CMV, is associated, whether it's symptomatic or asymptomatic, has been associated with increased incidence of allograft vasculopathy. Also, there is some suggestions that donor or recipient hepatitis B or donor hepatitis C is also associated with increased risk of allograft vasculopathy. It's usually diffuse, and you see diffuse intimal hyperplasia affecting both the epicardial and vessels and the microcirculation. Plaque rupture is quite uncommon. It's defined angiographically by stenosis of more than 50% and by intravascular ultrasound increase in an intimal thickening of more than 0.5 millimeter. I'll show you examples here of 3 patients that demonstrate 3 things. One is that it's quite diffuse, 2, it can be progressive, and 3, the uncommon type, which is the discrete. Sorry, so just not. Just not. It doesn't run here the video. It's just show the. I want to run video. It's not running. Just a. Okay. ما في video. Oh, sorry. Okay, so we'll just go back to. Yeah, unfortunately, I could have. Okay. It's not.
It's okay, Jehad.
Yeah, it's okay. I'm just running the.
It doesn't work.
Yeah, it doesn't work. I know.
Mentioned last time.
Okay. Well, anyways. So we'll move then to the management. The first line of management is aggressive management of risk factors. This is a study published in the New England in the New England Journal of Medicine in 1995, looking at use of pravastatin, which is a lipid-lowering agent, in patients who have undergone transplantation. They were randomized to receive either pravastatin or control, and they looked at the survival, and it's clearly shown that patients who received pravastatin had a better survival compared with the control group. Use of proliferation signal inhibitor has also been shown to reduce the progression of the disease. This is another study which was published in Circulation in 2003, comparing patients who received rapamycin compared with control. And as you can see, that patients who received rapamycin had a better outcome, not only in terms of survival, but in terms also of progression of vasculopathy as confirmed by angiography and intravascular ultrasound. PTCA can be used for focal lesions, but retransplantation is the treatment for patients who have diffuse severe allograft vasculopathy. Prevention and management of infection. Infection remains an important cause of mortality with a predictable pattern with higher risk in the first year, and which becomes less as time goes. Several factors have contributed to the improvement and the changing face of infection in solid organ transplantation, including introduction of prophylaxis for bacterial and viral infections, early withdrawal of corticosteroids, and introduction of new antimicrobial agents. What about malignancy? Still, it's a leading cause of death for those who survive beyond 5 years. It equals cardiac allograft vasculopathy as a leading cause of death. This is from the last report from ISHLT, and if you look at incidence of malignancy or freedom from malignancy by era, the last between 2001 and 2008, represented in the blue line compared with the green line, it shows that there is the incidence or the freedom from malignancy is higher in the recent era. And this is not only overall, but if you look at every type of malignancy, be it skin cancer, lymphoma, or other malignancies. So it's across the board. In addition, introduction of proliferation signal inhibitor has been shown in some studies to reduce the progression of cancer, and in some cases even cause regression. Advances also in treatment of lymphomas and advances in the treatment of invasive cancer. Renal failure it increases with older and sicker recipients, and this is what we are facing now in our population. It's a risk factor for short-term and long-term mortality. These are the risk factors for acute and chronic renal failure, and both pre-transplant creatinine and diabetes mellitus are uncommon for both groups. For the acute renal failure, also duration of bypass, hypoalbuminemia. For chronic renal failure, post-op acute renal failure, and HLA hypersensitization. The incidence of severe renal dysfunction have dropped also. This is the last report from ISHLT, and this is stratified by era. The blue line represents the area between 2001 and 2008, and clearly shows that there is an improvement and the less incidence of renal dysfunction compared with the previous years. This probably has to do with the better management of immunosuppression, less with minimization of immunosuppressive therapy, and with better monitoring. Use of proliferation signal inhibitor has been shown to improve renal function. This is a study which was published in Transplantation 2006. They took 10 patients who were transplanted and had calcineurin inhibitor-induced nephrotoxicity, and they were switched to rapamycin. And as you can see, that the serum creatinine has dropped significantly over time. In conclusion, heart transplant continues to offer a better quality and length of life. With the better understanding of alloimmune response, There has been an improved monitoring of rejection, development of better immunosuppressive regimens, and in the future, with further advances in immunosuppression protocols, organ preservation, and use of more specific immune monitoring tools, we're expecting a better survival, and if one day comes that we achieve immune tolerance, we will have a normal lifespan and normal quality of life. And with that, I conclude my presentation. Thank you.
Thank you very much, Dr. Jehad. Please stay for a couple of questions if تفضلي.
Thank you for the presentation, which I enjoyed very much. As regard the transplant vasculopathy and its relation to the immunosuppression, it's evident that the CNI is more safe than the anti-TOR as regard to the native heart. Is this match with the transplanted heart? This is number one.
Sorry, I missed the, is it? لا, I cannot hear you.
The CNI, the cyclosporin and the tacrolimus is much safe than the anti-TORs like the rapamune as regard the vasculopathy and the cardiovascular comorbidity. This applied to the native heart, to the original heart. This could be applied to the transplanted heart as well. This is number one.
The rapamycin is, in terms of vasculopathy, is a better drug to use in patients who have established coronary vasculopathy. So I'm not sure, you're talking about the native heart.
The original heart. You are talking about the transplanted heart.
Yes.
This match also the transplanted
yes.
heart. Am I sure?
Yes.
Okay.
Yes.
And the selection of the CNI as tacrolimus, is it based on that fact or?
No, the use of tacrolimus is not related.
Because you use the CNI more than the rapamune.
No. The use of rapamune is used more often in patients who have coronary vasculopathy, not the tacrolimus or cyclosporin.
Yeah. Are you asking about patients who had other than the heart transplant? What happens to their hearts?
No, to the patient with the transplanted heart. Okay.
Obviously, it's a multifactorial, so very difficult to answer. Now, how many patients of your patients had retransplant?
We had one patient, but unfortunately he was because of early graft failure, and that was the only one that we had for treatment.
And how many had intervention by BTC and stents?
We had two patients. I was going to show you two patients. One had multi-vessel angioplasty, including left main and left circumflex artery, but he progressed and he occluded his right coronary artery, so it was a progressive disease. The other one had a focal stenosis, and she had a follow-up angiography, and it was still patent.
Okay. Thanks very much, Dr. Jehad. Thank you. Dr. Isa.